Good afternoon, ladies and gentlemen. A year ago, I had the privilege of addressing you in Manchester, and I promised you that I would find a way to make sure that PCTs were held to account for practice-based commissioning. I believe I'm discharging that responsibility, but you will be the judges of that in the next 20 minutes or so. I also, last year in Manchester, said that we would provide support to those practice-based commissioners that were trying valiantly against the best efforts of some PCTs. I'll say more about that. And also, as Alan Johnson has released today, I am the Director General that's responsible for the integrated care organisations as part of the new primary and community care strategy. So in case anybody's in any doubt that your moment has arrived, I think I would ask for your indulgence for the next 20 minutes, as I suggest there's never been a better time to be a practice-based commissioner. There's no doubt in my mind whatsoever that over the next 5, 7, 10 years, the theory and the practice will gravitate towards primary care. I'm also aware, by the way, because we reflect on some of the practice and policy that we develop in the Department of Health, that some of you in the audience would think that world-class commissioning is a distraction. Some GPs, quite, I think rightly, suggesting that if this system allows PCTs to contemplate their navels for too long, it will have failed. But I want you to remember two things, if I may. Their strength will be and is your strength. For 60 years, the NHS has been largely defined by provision in primary care, but most importantly, secondary care. And for the last 20 years since working for patients in 1989, 1990, when I joined the NHS as a management trainee, the purchaser-provider split has always been dominated by supply and provision, usually in hospitals. So, of course, it's not possible to make PCTs world-class commissioners overnight. Of course, it's absolutely necessary and desirable for them to be better at their game as we head into more interesting economic turbulence. And of course, it's absolutely a no-brainer for PCTs that think they can affect change without giving the full support of resources and commitment to practice-based commissioners. The thing that I've learned is that you cannot rely on the benign benevolence of PCTs to make practice-based commissioning work. And that's why in the primary and community care strategy, we talk about a sense of right and entitlement. A right to clinical information, a right to financial information, a right to management support, and a right to financial support as well, with incentives for practice-based commissioners that want to go further faster. And therefore, in a sense, if the primary and community care strategy is trying to do anything in the next 18 months to 2 years, it's making sure that you get a sense of right and entitlement. So when I did promise you last year that I would hold PCTs to account for practice-based commissioning, you can see in the world's first compliance and assurance system for commissioners that we've done just that. So what we've asked PCTs to do is put their money where their ambition should be, demystify the interventions that you need to make to improve population health. Now, of course, practice-based commissioning has a fundamental role in that. You can't do it all, but neither can the PCT. They don't have to compete every single contract. They don't have to compete every single service line. They have to have the authority to decide when they're not getting sufficient responsiveness or indeed cost effectiveness. And without that encouragement or that option, they remain passive grant givers of money, of state money, to beneficiaries that are not, I think, encouraged to innovate and do more for patients. Now, that may be a fairly hard-nosed message, but I think it is pretty important. These 11 competencies do have an evidence base behind them. I'm not going to go through them again today. On the face of it, they seem like statements of motherhood and apple pie. As you dig a bit deeper, look at number 4. This is where we will ensure that PCTs support formally, through a sense of right and entitlement, practice-based commissioners. And that will happen with effect from the beginning of the new calendar year. But of course, they're being judged on it this year. There is too much red tape in terms of governance. So I've heard quite a lot of stories of the £10,000 business case going nowhere. I've had even more stories about the £50,000 business case not going particularly quickly. And therefore, the issues about freedoms and rights will be extended to proportionate governance as well. And that means as practice-based commissioners get into their stride, we will give you more freedom not to produce business cases. What a great freedom that is. The theory is quite simple. The world-class commissioning assurance and compliance regime will make sure that PCTs are held to account for supporting practice-based commissioning. The work of Lord Darcy, myself and others on the primary community care strategy give 4 new rights and entitlements. PBC, as they want to go further faster, will be encouraged by proportionate governance that allows you to take educated innovation and risk. And of course, for those that really do want to move, shake, rattle and roll even more quickly, the prospects of integrated care organisations, and there aren't many rules attached to them. And I think we could have a conversation about that later on. As I start to slow down towards the end of my presentation, compliance and assurance, rights and entitlements, freedoms and support, national support, local support, money coming from the centre to support organisations like yours, improve and also take remedial action where that's necessary. And then the ambition bit is trying to nail nationally by, I reckon, with a fair wind, January, February at the latest, what you want in terms of governance and risk-taking and innovation.